Now move on to the next presentation by Dr. Aditya Maitre on transpupillary thermotherapy for juxtapapillary and subfoveal choroidal hemangiomas.
Good afternoon. So I'll be presenting about role of TTT in treating juxtapapillary and subfoveal choroidal hemangiomas. So choroidal hemangioma, being a benign vascular hematoma, warrants treatment only when it involves subretinal fluid at the macula or a CME. Most of these lesions are located at or around the posterior pole. So TTT is an effective, convenient and inexpensive way of treating these tumors by causing hyperthermia and occlusion of the vessels within the tumor. But the problem is that it has a limitation when treating subfoveal or juxtapapillary tumors because of the potential risk of vision loss in these cases. So the alternative options we have is PDT, which is ideal for subfoveal CCH, but it is currently unavailable and was expensive. Other option can be a plaque brachytherapy, which then needs 2 surgeries, has accessibility logistic issues, and also relatively expensive. What an alternative approach would be to do TTT to these subset of cases with a fovea and disc margin sparing approach. So in our study, we report 5 cases with juxtapapillary and or subfoveally located tumors, all of whom had SRF at macula with or without cystoid macular edema. And they underwent multimodal imaging with OCT, ultrasound and ICGA. And the TTT was done sparing the disc margin as well as a region 500 microns around the fovea to cover the entire lesion with overlapping spots, as you can see in the treatment. So the patients were followed up monthly and to monitor the SRF height till the complete resolution of fluid was noted. And retreatment could be done if the SRF persisted at macula on OCT. But the TTT was applied only to the non-regressed or residually active portions of the lesion in the extrafoveal and extrapapillary area again. And the outcome measures for change in visual acuity, reduction in subretinal fluid, central macular thickness and tumor thickness. Here is one more example of treatment. So coming to results, the 5 eyes of 5 patients had a median presenting age of 52 years with median duration of symptoms being 4 months. The CCH, the hemangioma involved the disc margin in 3 cases. As you can see in these 3 cases, it involved the juxtapapillary area. And it involved the macula in 2 cases. As you can see in these are the 2 cases with macula involvement. So the median baseline tumor thickness was 3. Number of TTT sessions ranged from 1 to 3, although most patients required just 1 session, 3 of them. The power of TTT used was ranged between 250 to 500 milliwatts. And the median follow-up we had was of 7 months, and the visual acuity improved from a median of logMAR 0.5, which is about 624, to a 612 0.3 as a median acuity. So vision improved in 3 of the cases and remains stabilized and unchanged in 2 cases. So as you can see here, all the cases showed a complete resolution of SRF and reduction in tumor height. One of the cases developed BRVO following the 3rd sitting of TTT, as you can see in the middle image, but it responded well to a single injection of anti-VEGF. So this is the full tabulation of all the cases and their details. So juxtapapillary choroidal circumscribed in choroidal hemangiomas, the TTT has a rare risk of causing thermal papillopathy, has been reported by Shields et al. When reporting outcomes of juxtapapillary choroidal melanomas. So a disc sparing approach is recommended. For subfoveal hemangiomas, as I mentioned, PDT would be an ideal option, but TTT can be safely used to treat the extrafoveal portion of the tumor. That itself is most of the times enough to take care of the fluid. Complete resolution of fluid has been reported with this approach in the past, because the goal of treatment in hemangioma is resolution of fluid and not destruction of the tumor, because it's not a malignant tumor. And if you can treat the extrafoveal, extrapapillary portion of the tumor, that itself can cause the remodeling required enough to cause resolution of the fluid in most of the cases. So in our study, we attempted to use a lower TTT power in areas closer to the fovea and optic disc, kind of a calibrated mild under treatment compared to those areas which are away from it. So retreatments were needed only in 2 of the 5 cases, and only the remaining active portions of the tumor were retreated for enhanced safety. Retinal vascular occlusion can be a rare complication of TTT, and especially following those cases which need repeat treatments. Thank you.
Thank you, Dr. Aditya.
One thing I want to add, like treatment with a plaque nowadays is not expensive.
Correct.
So BARC has introduced indigenous ruthenium plaque, and with like the rate at a very economical price we can procure
Correct,
it.
but compared to TTT, I was just making
Compare.
a
Now
comparison
the
with
issue
TTT.
is that TTT, what is the difference between the green laser and the TTT? The main role of TTT, you have to ablate the surface, any type of tumor, very malignant or benign tumor.
Yeah.
So green laser, like in your images you have shown, you have applied TTT at the margin of the tumor. So that is being done, was being done by a green laser initially. When the TTT was introduced, the main thing was that you have to ablate the surface of the.
Yeah, so we did treat the
So
surface
at
with
the
mild,
margin,
just a
because,
slight overlap around the
extrafoveal
margin.
and these are very near to the optic disc.
Yes.
So there is a possibility, even if you are hitting at the margin and all those away from the optic, there is a possibility the scar and all those might increase.
Yeah, so that's
in
why we spared
future.
the
Yeah.
disc margin, and a 500 microns around the fovea was not touched.
Long-term follow-up is required in
Yes.
all these cases,
Yes.
whether it is feasible or not.